Good afternoon, everyone, and I will try to keep my talk short because I know it's already getting close to lunch hour, and I'm getting hungry myself. I got up early to go to another conference in Marina del Rey on prostate cancer. So, but I'm glad that Steve Wong has invited me here because bladder preservation, treating bladder cancer with chemo-radiation, is not always bladder preservation is not always discussed and presented to patients and their families as a viable option. And it is. So, okay, that's fine. So my name is Christopher King. I've been at UCLA for about a year and a half, and I'm a radiation oncologist. I treat mostly GU cancers. So primarily prostate cancer, bladder cancer, testicular cancer. And okay, so just a few facts. I mean, you all have heard numerous talks, and you're well informed on bladder cancer. But I just review, and as I was putting these slides together, it's for myself also to review. How many new diagnoses of bladder cancer occur a year? About 54,000. So it's not the most common cancer, but it's fairly common. About a third are muscle-invasive, so meaning that they need a radical treatment. And half of these diagnosis of muscle-invasive cancers, unfortunately, are develop metastatic disease. And the histology, the tumor cell type, most of them are transitional cell cancer, but there's some other tumor cell types that occur in the bladder. And the location within the bladder is important, especially as a radiation oncologist, because we need to direct our radiation treatments to the anatomy of the bladder. And so for surgeons going to take out the entire bladder may not matter as much to them from a technical standpoint, but as a radiation doctor it does. And so most of the tumors do occur in the trigone or the posterior lateral walls or the bladder neck, but we need that crucial piece of anatomical information when the diagnosis is made so that we can treat it properly. And the nodes, the lymph nodes that are first involved when bladder cancer spreads are in the pelvis, the external internal iliacs, the presacral nodes. And unfortunately, when bladder cancer spreads, it goes to bone, lung, liver. So the treatment of bladder cancer, and when I say bladder cancer, I mean muscle-invasive bladder cancer. Is there such a thing as a gold standard? Well, if you live in the United States, as we do, radical cystectomy, so surgery with lymph node dissection, is the standard of care. Now, where does that come from? If you were to live in the UK or in Europe, in fact, the primary treatment for muscle-invasive bladder cancer is not surgery; it's bladder preservation, chemo-radiation. So, how can that be? Are they behind in Europe? I don't think so. Are they more advanced? Maybe. Are they biased, or are we biased? I'll leave that up to you, and I'll show you the data so you can make up your own mind. But this is a current dilemma that we face with bladder cancer in the U.S. is lack of randomized trials, meaning well-designed studies that compare one treatment arm, surgery, versus chemo-radiation. Most of medicine in the U.S. is evidence-based, and before we change practice, we need randomized trials. They're extremely difficult to perform, especially in the U.S. There's so many hoops to go through, so many guidelines, so many restrictions, that in fact running randomized trials is much easier in Europe than it is here, unfortunately. I want to talk just a little bit about how imprecise is our staging. As you know, when we diagnose bladder cancer, it's critical to know what the stage is, how extensive it is, because we tailor our treatments depending on the stage, what we call the stage, the extent of disease. Unlike some other cancers where stage can be known precisely. For bladder cancer, it's very difficult, and a CAT scan, an MRI, a PET scan are very imprecise, and that makes our treatment recommendations very difficult. And if you look at, and so how do we know that we're unable to stage bladder cancer accurately? You do all the imaging, the CTs, the MRIs, all the imaging, and then patients have surgery, and then we know what the final pathology is, what the final stage is, and about 20% are overstaged, meaning that we thought they had worse cancer than they actually have. But more importantly, about half of them, 50%, are understage. So at the time of surgery, we find out that they have more extensive cancer. So going back to this, so we don't really know up front what we're dealing with. And so if a surgeon is going to operate, he or she will operate, and whatever they've removed, this is what the patient had, this is what they have. So if you're comparing then surgery to bladder preservation, we don't have the surgical specimen to look at. We don't know what the true pathologic stage is. What we have is the imprecise scans. So is it fair then to compare surgery to bladder preservation or chemo-radiation? So surgery has a lot of biases in its favor. First of all, surgeons would operate preferentially on younger, healthier patients, so the outcomes are expected to be better. They exclude patients with intraoperative metastatic disease. Up to 15% of patients are open up and are found to have inoperable tumor. As a bladder preservation physician, we don't have that information. So we cannot exclude those very high-risk, incurable patients. We talked about the staging. Obviously, surgery has accurate staging. As radiation oncologists, we don't have that staging information available to us. And I showed you that about half of the patients are actually found to have higher stage. Randomized trials comparing surgery to bladder preservation are unlikely to occur. One of the major reasons is that there's a lot of inherent biases from surgeons in the United States. They're the one making the diagnosis. They're the one who are first have contact with the patients. And then it's really difficult to compare treatments when they're so radically different. Obviously, surgery can be disfiguring. You need good data before you're going to make decisions. It's not choosing between drug A and drug B. It's choosing between radical surgery and bladder preservation. So the treatments being so radically different, very difficult to conduct clinical trials. So the surgeons will report their data. And again, I talked about some of the reasons why they have biases in favor of reporting their data. And I understand I don't want to present a lot of tables and graphs, but when you're talking about cancer treatments, any medical treatment, you do have to show a little bit of data, a little bit of curves, but I will not show too much boring data, I hope. So this is, if you look at survival as a function of years after cystectomy, this is a large surgical series from USC. It'll show you what the 5-year overall survival rate is and then 10-year overall survival. Obviously, 60% is an excellent survival. Obviously, we want to push that up, but this is an excellent survival. And then so surgeons, when they present their data and compare it to bladder preservation, will present such data as I just presented. So here I'm looking at good data that reports 5-year survival rates with the bladder preservation. Bladder preservation I'll use synonymously with chemo-radiation. So preserving the bladder, treating with chemotherapy and radiation versus surgery. And you have data in Mass General, Erlangen in Germany, and RTOG, mostly US-led trial, using chemo and radiation, and look at their survival. It's about 50%. And then you look at the surgical series. We talked about the USC. We talked about, there's in Switzerland, the Memorial Sloan Kettering. You could say, well, sure, you guys do okay, but we do better. So obviously, if you're a patient, you're going to go for the better. I hope there are no USC surgeons here today. Steve, are there any? Oh, sorry. I'll be sitting over there. Little do they tell you, however, and again, some of this I'm doing, tongue-in-cheek, just to make a point. But little do they tell you when they're reporting. So this is the USC data, and so total cohort, so a very large series, over 1,000 patients, 60% survival at 5 years. Little do they tell you that a great number of their patients had, in fact, remember how I talked about the inaccuracy of staging and how at the time of surgery you find sometimes worse cancer than you thought. In their surgical series, little they tell you when they do the sum that many of their patients, in fact, and those who did the best, 80%, 75%, in fact had non-invasive disease or had very superficially invasive disease. And if you go down then, patients who have worse disease, stage T2, stage T3, obviously you can see these numbers go down. You average them all out, you get 60%. Is that fair to compare surgical series that have all these biases in their favor to the bladder preservation where we don't have this information of stage? And so let us look at just muscle-invasive disease, pathologic stage T2A to T4A. And let's look at this subset of patients because these are the ones that we will see when we do chemo-radiation. And their survival then is not 60%, it's about 50%. So now let's go back and look at our bladder preservation. Again, 5-year survival rate with chemo-radiation, the bladder preservation, the chemo-radiation versus the surgery. I'll leave it up to you, but I would say as an oncologist, they all do about the same. So the survival is about the same with surgery or with bladder preservation. Looking at other series that now not only have 5-year but have longer 10-year comparisons between surgery and bladder preservation. We'll have the surgical series here, the bladder preservation chemo-radiation here, the stage that they were at, the number of patients in these series. And again, you look at the 5-year overall survival, about 40 to 45%. Same with the chemo-radiation. 10-year survival, about 30%. The same with the same. So if you're just looking at the survival, the data tells us surgery or chemoradiation, same survival rate. Many of these patients, unless they had a neo-bladder or successful neo-bladder reconstruction, are without bladder. With these bladder preservation, we are preserving the bladder. Survival is the same, you still have your bladder. Again, I'm making some of these points a little bit more strongly, and apologies to all the surgeons in the room who will never speak to me or refer patients to me again. So why bladder? Why have we never been able to conduct a randomized trial? I don't know. The same issues happened a couple of decades ago. Breast cancer was mastectomy versus lumpectomy and radiation. The same with larynx cancer, total laryngectomy versus chemotherapy and radiation, so organ preservation. The same with anal cancer, pelvic, resection of the rectum versus preserving your normal rectal flow and preserving your organ, your anus, and with chemoradiations. It's been shown randomized trial have shown that organ preservation is as successful as radical surgery in these diseases. Why not bladder cancer? So chemotherapy, and Dr. Steve Wong talked about much of the rationale to use toxic drugs. And for radiation, we're using it for a slightly different reason. I mean, in part for the same reason, in part for different reason. As a radiation sensitizer, we want to make the cell kill properties of ionizing radiation even better with drugs that can enhance that effect. And then also, of course, chemotherapy will be, at the same time that we deliver radiation, will be addressing potential unseen occult microscopic disease. And the major drugs are the cisplatin, of course, 5-FU, and then more recently gemcitabine, all kind of work in pretty much the same way in terms of radiation sensitizing. They mostly prevent DNA repair. So radiation, ionizing radiation causes DNA damage, and these drugs prevents some of the repair mechanisms, and so it enhances the cell kill effect of radiation. Mind you, so all of the data that I showed you on the outcomes, the survival with chemo-radiation, was in an era where radiation was fairly crude in terms of its technique. The fields that were treated were a large pelvic field to include so this is just a plain view of the pelvis, of the bladder here, and the schema of the bladder tumor. We treated the whole pelvis with the field of radiation and then a boost to the tumors. That was our, what we call APPA, the front and the back field. It was a 4-field technique, just aiming at the pelvis from 4 fields. And then the lateral, the side fields, again, treating the whole pelvis for part of the dose, and then the tumor for the posterior. So you can see, obviously, we're treating a lot of when we treat the whole field, a lot of normal bladder that doesn't need to be irradiated. We're treating a lot of small bowel. We're treating a lot of rectum. We know radiation works. It can be toxic, but this is radiation then. Radiation now is actually fairly sophisticated. This is a patient actually that is currently on treatment. He's about midway. He's in his late 70s, was a former smoker, and was initially found to have superficial disease a few years ago and found to have invasive disease. This is a man, and you will note, for those of you who are good at anatomy, he is missing his prostate. He had radical prostatectomy years ago. His PSA is undetectable, so he's been cured of his prostate cancer. But the dilemma then, when he was diagnosed with bladder cancer, was could he have radical cystectomy? And there's some patients who were not good candidates for radical surgery, and those are patients with prior pelvic surgery, simply because of a lot of adhesions. The surgeon was very worried that because of prior surgery, there would be a lot of adhesions, and there may be serious damage to the rectum, and potentially needing then a colostomy. So surgery was not an ideal option for him, but bladder preservation is. His tumor was complicated by the fact that it was located at the dome. You know, I said most tumors are located in the bladder neck or in the trigone, but some tumors occur elsewhere, and this one occurred in the dome. So CAT scan with full bladder, being able to not only visualize where the tumor is, but also going by the urologist cystoscopy reports, we're able to design a radiation field that can really carve itself out and give high dose to the bladder tumor, spare most of the bladder, spare most of the bowel. So the high dose goes to the main bladder tumor, and this lower green dose goes to the pelvic lymph nodes. So this is a front view. You see a lateral view. See how we're sparing a lot of the bowel. See how we're sparing a lot of the rectum, and treating pelvic nodes and bringing the bladder tumor to a high dose. This technique called intensity modulated radiotherapy, fairly modern technology that allows us to sculpt and shape the profile of radiation to fit an irregular internal anatomy. We expect, therefore, that the results of radiation will be, with chemotherapy, as good as all the other series that I showed you, but even better in terms of having less toxicity. And with this technique, we're able then to deliver even higher doses, radiation doses, to the bladder tumors safely. And so we expect even improved success. This is just on the imaging you can see the bladder thickening, and so we're able to draw slice by slice the bladder tumor. We're able on a daily basis, the patient on the radiation treatment linear accelerator, to obtain a CAT scan in the treatment position and make sure that the bladder is with the same fullness as it is on the treatment planning, the initial CAT scan. So we have reproducible anatomy on a daily basis. Bless you. And you can see how we're able to then sculpt the profile to deliver high dose to the tumor, lesser dose in this lighter green to the rectum, and then treating the pelvic lymph nodes as well. And just as more images of the same patient. All right, it's one thing to say survival is the same as surgery, but what about quality of life with bladder preservation, chemo-radiation? Obviously, during the treatment, and everything comes at a cost, and so during the treatment, there is a fairly high rate of temporary irritative symptoms, kind of the acute, the early morbidity or toxicity. And these are some burning, mild burning with urination, frequency in urination, some urgency, and some rectal urgency as well. Should be kept in mind that these are experienced, of course, by all patients, but they're nothing that would lead to a hospitalization or surgery or the need for intervention other than changing your diet, reducing caffeine, and taking some mild medications. So these are the side effects during the treatment, but they all resolve. A lot of the criticism from surgeons would be, well, after radiation, you really have just a fibrotic, tiny bladder that is unable to function, kind of a useless bladder, so what was the point? Well, that happens not to be true. In fact, in terms of bladder function, the overwhelming majority of patients maintain their bladder continence, and bladder function and capacity. There's very little low incidence, less than 5%, of urinary incontinence or severe bleeding. And in addition to that, there's also preservation of sexual function as well, as opposed to patients having radical cystectomy. Again, I don't want to show too much data. I know looking at tables and numbers is kind of boring, but let's look at the late toxicity, so late pelvic toxicity after chemo-radiation. And not many studies have followed their patients closely to monitor this, but there are some that have. So these are these are chemo-radiation trials that have followed quality of life and toxicity. What we're worried about when we talk about late toxicity is high-grade toxicity. So grade 3 or higher urinary GU or grade 3 or higher GI rectal complications. And as you can see, it happens in few patients. So you can see how many patients. So very few patients have lasting high-grade toxicity. By late toxicity, we mean happening 6 months or later after treatment. Even patients who had grade 3 toxicity, it resolves usually within about 6-7 months. And in all these patients that had grade 3, they all resolve except one who had persistent urinary high-grade symptoms. There was no grade 4 toxicity and no treatment death. So, in fact, the late toxicity with bladder preservation is, I would say, outstanding. The time course of the urinary and the GI usually comes on within the first year or so and then plateaus out. So then it's not as if the toxicity year by year keeps going up to very high toxicity rates. It kind of plateaus out. So these low rates, if you have it, you know, within the first year, year and a half, and then they plateau out. So I talked about some toxicity of bladder preservation. You know, to be fair, and to be fair, I wasn't here with in previous talks that were this morning. But what about, so surgeons might say then, well, all this is well and good, but, you know, we can create a new bladder, and this Neo-bladder, and so, you know, what do you have to say to that? And I say, okay, well, let's look at how well patients do with the Neo-bladder. And there's been a couple of studies at Mayo Clinic and then a pooled analysis from the UK. The Mayo Clinic, so these were all women, median age, follow-up of 2.5 years or so. About 5% develop a fistula, connection between the Neo-bladder and bowel. Most of them have had excellent daytime continence, but again, 43% nighttime incontinence, not insubstantial in terms of quality of life, and about a third require intermittent self-catheterization. And kind of the same results, obviously, it depends on the surgical techniques, of course, and selecting ideal patients for Neo-bladder. So continence rate is usually excellent, but a certain amount of nighttime incontinence and then a certain amount of self-catheterization. So nothing is without toxicity, and again, it's often up to the physician and the patient to decide which toxicity they're more willing to accept. Not every patient can get bladder preservation, radiation. If you've had prior pelvic radiation for any other tumors, you're not a candidate for this. If you have pelvic inflammatory disease or inflammatory bowel disease, you're not a candidate. If you have urinary incontinence, the thought here being, well, if your bladder is not good for you now, why preserve an organ that's more of a nuisance? And so this is a relative contraindication to bladder preservation. You have the other side, if you have an atonic bladder, a bladder that just, again, that's a non-functional, non-useful. If you have a bladder diverticulum, it's thought that having a diverticulum, kind of an outpouching where the wall of the bladder is extremely thin, that is at risk after chemo-radiation of rupturing. And so this is usually, again, a relative contraindication to bladder preservation. And if you have a lot of severe adhesions from prior surgeries, again, another relative contraindication against radiation to the pelvis. So just a couple of slides. So we do have a bladder preservation at UCLA clinical protocol, in primary inclusion, again, patients who are thought to have muscle-invasive T2 to T4 disease. Hopefully node negative, but if we have imaging or biopsy that is node positive, again, we're able to sculpt and deliver significant dose and treat the pelvic lymph nodes. In the past, a maximum transurethral resection of the bladder tumor was essential. We don't believe it's essential anymore because we're able to deliver higher doses of radiation. Of course, if they're going to get chemotherapy and good chemotherapy, they have to have the ability, their kidney function has to be adequate for that. Many patients that we see are patients who have declined surgery. A lot of these patients are not good candidates for Neo-bladder, and so they're declining surgery because they don't want the ureterostomy. They want to attempt to preserve their bladder, or they're medically inoperable. Either they're too old or have other medical or issues that would make surgery much too risky. There's just some of the technical details of our bladder preservation protocol. Again, our treatment it can be tedious to deliver, but incredibly accurate, especially when you compare radiation done 5 to 10 years ago. We get a cone beam every single day, just within a minute. A cone beam CT scan is just a CAT scan that's obtainable on the treatment linear accelerator in the treatment position, so the patient doesn't have to move from the CAT scanner to the treatment table. And we can acquire this image within 1 minute, and within 20 seconds reconstruct in 3 dimensions. So we can line up the internal 3-dimensional anatomy to the radiation fields. We have ability to target lymph nodes, and with that we're going to spare bowel, rectum, and normal bladder from injury from radiation. And our techniques allow us also to abbreviate the course of radiation treatment now to 5 weeks. More standard radiation treatment usually took 7.5 weeks to deliver. And so I think this is my last slide. Yes, my last slide. So, the schema, we select patients. They undergo TURBT, but a maximum and second TURBT prior to bladder preservation is not required. And chemo-radiation, again, 5 weeks, no interruption in treatment, and with good technology. And then obviously adjuvant chemotherapy and surveillance are part of bladder preservation. So with that, I thank you for your patience. And